Will we start, Sanket?
Yes, ma'am. We can start.
Morning to all of you. We've been planning this class for some time, but I always preferred if somebody presented a case and then I moderated, but that doesn't seem to be happening. So we decided we'll do problems in cardiology like I did for the DNB, but I didn't want to repeat myself, but I think I also will get bored. So I made different problems. Uh, the DNB class was on valvular heart disease, but this we will go all around the place. And so you have a wide variety of cases that we are presenting. So you will have to answer like you did in the chat box, and that's how we'll keep the discussion going. So let me move on to my first case. Okay. 67-year-old man with no comorbidities is brought with PND of 2 months duration. He also has speed edema of 1 month duration. On examination, he has an irregular pulse, BP of 102/78. JVP is raised with some prominent wave. The candidate is not able to identify what it is. Examination reveals an apex in the 6th left intercostal space and a pansystolic murmur in the mitral area. He also has a systolic murmur in the lower parasternal region. P2 is normal. There's no other murmur. What is the diagnosis? Please go ahead and answer on the chat box, please. Is anybody answering? Sorry.
Yes, ma'am. There are answers.
Oh, okay. I'm not seeing the chat box. I'm wondering where it is now. 1 minute. Sorry. Where is it? I'm not seeing.
It will be just beside the participant in the down.
Okay, I got it. Yeah, okay. Yeah, got it. Yeah, fine. Somebody is saying mitral regurgitation with AF. Yeah, DCM, MR, AF, mitral regurgitation with AF with PH, dilate cardiomyopathy with MR. Okay, a lot of answers have come in. Okay, now those of you are calling it mitral regurgitation with AF. There is also another murmur here. Can you see? There's one more systolic murmur in the lower left parasternal region. So it's just not one mitral regurgitation. There may be two murmurs. And if you think it is the same murmur that is being heard, how do you differentiate an MR which is heard in the parasternal region from an MR and a TR separately? Because this confusion can happen to all of us. So how do you differentiate the two? Okay, somebody is saying decarbonylose sign. Okay, correct. Okay, you look for the carbonylose sign, and also you do what is called inching, isn't it? You auscultate in the apex and then move towards the tricuspid area. If there is a gap and then there's another murmur in the tricuspid area, probably there are two different murmurs and not the same murmur. And as you move away from the mitral area, if the murmur actually diminishes in intensity, but there's no gap, then it's probably the mitral murmur which is heard. Correct. Okay. But remember, a decarbonylose sign will be useful only when you have a grade 2 murmur. You can't differentiate between a grade 3 and a grade 4. It's impossible to do a dynamic auscultation at that level. Right. So let's assume that he has two murmurs. Okay. And then somebody said there is pulmonary artery hypertension. Where is the pulmonary artery hypertension? Somebody said there is a pulmonary artery hypertension. Is it there? Probably not, isn't it? Because you're getting a normal P2 and there's no other murmur. So there's no evidence of a pulmonary artery hypertension for us to say that there is something there. Okay, right. So you have an MR, TR, and you have no pulmonary artery hypertension. And then, of course, there's an irregular pulse. So you're thinking that there is an AF. Okay. So most of you have answered that it is a dilated cardiomyopathy. So let's see whether we are right. Okay. So there is a CCF. There's a biventricular failure. There's an AF. Probable DCM. Correct. I agree with all of this. This is probably the best diagnosis in the current context, that you have two murmurs, no pulmonary artery hypertension, a dilated heart, and an AF, all of which fit into DCM. Now, I want you to answer this question. Why is there no pulmonary artery hypertension? Why can't I say that he had a MR and then that produced a TR? Why is there no pulmonary artery hypertension? Anybody? Yeah, go on. Anybody? It is normal. Okay, that I agree. I'm asking you mechanism-wise. I'm not saying findings-wise. I'm saying, okay, this man has a left heart disease. Why are we saying that a DCM may not have much pulmonary artery hypertension? Dilatation of ventricle. Okay, that doesn't mean there's no pulmonary artery hypertension, right? So what's the mechanism of a pulmonary artery hypertension in a left heart failure? What's the mechanism? What mechanisms are we talking about when we have a pulmonary artery hypertension in a left heart failure? Okay, somebody said duration of symptoms, right? For you, for a left heart failure to cause, a PND to translate into a pedal edema, you must have time, isn't it? You don't have the time. 2 months you had PND, 1 month you had pedal edema. Now that is not any way by which a left heart causes a right heart problem through the pulmonary artery hypertension, correct? So that tells you there is no pulmonary artery hypertension either by history or by examination, okay? And then we are asking what is the mechanisms, and somebody said LV diastolic failure. LV diastolic failure. Why not systolic failure? Yeah. Anyway, it has to go through the, the back pressure, right? Okay. That part is correct. There's a back pressure from the left heart, and then the LA pressure goes up, and then you have pulmonary artery hypertension coming over time. Correct. Why this time is involved? Why this time is involved? Because there can be anatomical changes over time, correct? The immediate pulmonary artery hypertension that you may get in a left heart failure is something that is, because of spasm of the vessels, and that can be because of anything, can be hypoxia, hypercarbia, acidosis, whatever you want, anything that constricts the pulmonary circulation will cause a pulmonary artery hypertension. Okay, fine. And then later on, the anatomical changes will come in. Somebody is talking about arterialization of the pulmonary veins. Okay, there is a thickening of the pulmonary arteries, right up to the anatomical changes that come in. That requires time. And in this patient, you never had time. You had a 2 months history of PND, 1 month history of pedal edema, and that history tells you probably they are not linked. And the examination also shows you there's no pulmonary artery hypertension. And so there is no time for that left heart failure to translate into something like a pulmonary artery hypertension and then cause a right heart failure. So in most DCMs, of course, if DCMs can last longer, then you can get. Previously, we were all told you'll never get a pulmonary artery hypertension in a DCM. That is not true nowadays, because you are having DCMs who are living longer and you are able to, maintain their quality of life for a longer period of time. And yes, you may get a component of pulmonary artery hypertension later on in the day. Nothing prevents that. But generally in life, you don't get. Okay. Now I want you to answer this question. What are the causes of combined MR and TR? MR and TR combined, your causes, please. Yeah. Go on. Okay, somebody says rheumatic. Go on. More causes. Rheumatic, arsinoid. MR, TR, isn't it? Okay, then go on. DCM, correct? Okay, right. Ostium primum defects, isn't it? Ostium primum defects, correct. You should think of rheumatic heart disease as number one. There's no doubt about it, because any rheumatic heart disease can, over a period of time cause a functional TR, a left side going to the right side. But if you have two coming, simultaneously in time, then you have to probably think that they are not linked. Okay. And yes, anything that involves the valve, isn't it? So that's why your endocardial quotient defects like you get in ostium primum and any other endocardial quotient defects even otherwise can cause an MR and TR, and all the collagens that you're talking about, and you're talking about marfans, all those things can cause, correct? Okay, so there are many causes where you get combination of this. We will again go back to that later. What is the etiology of this DCM? What etiology would you think of? for this DCM? What etiology would you think of? Go on, please. Okay, somebody saying ischemic. Okay, tachycardia-induced DCM. Go on. Yes. Go on, go on. Any more? Alcohol. Yeah. Go on. We never told you whether it's an alcoholic or not. We only said he didn't have any comorbidities. Okay, somebody's talking of toxins. Okay, then all the causes of DCM come here, isn't it? Okay, somebody said viral, inflammation, drugs, toxins, etc. Correct, correct. So you have to think when you have a 67-year-old with no comorbidities, then ischemic dilated cardiomyopathy is a misnomer, isn't it? It's a misnomer. A cardiomyopathy, by definition, is in the absence of a heart disease, primary involvement of the muscles, not really the coronaries that we are talking about. So, you, in the presence of hypertension, ischemic heart disease, you should not technically call it as a DCM, but ischemic dilated cardiomyopathy is probably the most common thing. So, even if it's a misnomer, we go on with that, right? And then, like what you all said, the other causes of DCM must be looked for, because some of them are reversible, like alcohol, beriberi, they're all reversible. So you can probably think of those things also, correct? So you have to look for an etiology because you want to know whether it can be treated or not. So I'll just put up the causes just for us to go through, right? Now, diabetic cardiomyopathy is something through ischemic, not through ischemic, both are possible, isn't it? So you can get something like, coronary artery disease, which is not involving the epicardial arteries and is involving the microvascular circulation in a diabetes. So that's possible. You could even call it cirrhotic DCM. That also can come. Viral chemo, collagen, peripartum, of course, not in this person, but otherwise, a peripartum cardiomyopathy is a very important cause in the younger people and women 6 months into the pregnancy, and then postpartum also you can get. So you must remember peripartum cardiomyopathy. In whom is it more common? Peripartum cardiomyopathy, whom is it more common? Which group of patients is it common to have a peripartum cardiomyopathy? Yes, multiparous women, isn't it? Multiparous women, okay. It's more common and more in the African descent and the older people, correct, okay. And one peripartum cardiomyopathy predisposes to another, okay. The next pregnancy is probably more dangerous, especially you should first document that it came back to normal after this pregnancy, then only you had, okay, fine. Right, collagen you all mentioned, and then tachycardia induced, yes, tachycardia of the atrial fibrillation has a higher heart rate, then tachycardia-induced cardiomyopathy is a good thing. In degenerative disorders like Friedreich's, all those neurodegenerative disorders which we are talking about, those, of course, not in this person, but you have to think of, okay. Then you said idiopathic, correct? A big portion of the dilated cardiomyopathy goes into idiopathic, and then the genetic anomalies that you talked about. But when you're looking at mainly what treatable cause you can think of, then it is always IHD, alcohol, diabetes, viral, post-viral, things like that. Okay, chemo, correct. That's an important cause, daunorubicin, things like that. When you're giving a chemotherapy, always you're worried adriamycin can cause cardiomyopathy, etc., etc. So that's your causes of cardiomyopathy that you would think of. And then we all talked about MRTR. So let's just look at those causes. So that is rheumatic heart disease is number one always. Then you have a DCM. You can also get in a restrictive cardiomyopathy. Okay, don't think that DCM only causes MR and TR. Restrictive cardiomyopathy, endomyocardial fibrosis can cause, MR and TR, and then AV canal cushion defects, Hunter-Hurler, and all the collagens that you talked about. They can also cause MR and TR. So your causes of MR and TR can be this. With pulmonary artery hypertension would be your, RHT. Without would be the other things, because they don't require a pulmonary artery hypertension to go through. Okay, fine. So let's move on. Okay, I think I moved to the next case. Yes. So let's look at the next case. A 10-year-old boy comes with fever and myalgia. He has been on various antibiotics for pneumonia, but the fever recurs after a few weeks. Examination reveals a grade 3 pansystolic murmur in lower left sternal parasternal region. So what do you think is the diagnosis? It's a 10-year-old boy, fever, myalgia, antibiotics for pneumonia. but the fever is recurring. Okay, and so somebody is calling it a VSD. Okay, because there's a grade 3 pansystolic murmur in the lower left sternum area. So why is he getting recurrent pneumonia now? Why is he getting recurrent pneumonia now? He's a VSD. Somebody call it acute rheumatic fever. How common is acute rheumatic fever? On the right side. Right? You have to call this a TR, right? Call this a TR. Yeah. Why is he getting recurrent pneumonia? Oh, somebody is saying because he has, what do you call it? Pulmonary plethora. Oh, that's recurrent respiratory infections you're talking about. Possible, but it's a little too much for an infection to have so much pneumonia, right? So if you have a fever and pneumonia coming, with a probable VSD, what are we thinking of? What are we thinking of? Okay, right. We are thinking of an infective endocarditis, isn't it? So infective endocarditis in a VSD will occur on which side of the heart? Which side of the heart will it come in? The right, isn't it? So it's got a jet. Okay, it's coming from the left to the right, and it's going to hit the wall there, and that's where you're going to get your vegetation, and that can go into the lung, and that's why a recurrent pneumonia in a young person with a 3/6 murmur, you probably have to think maybe he's got an infective endocarditis, and that's going into the lung and presenting as a recurrent pneumonia. Okay, so that's a good possibility that we think of. Now, keep that aside and just let's look at the VSD. What do you think will be his pulse and BP? What do you think will be his pulse and BP? Yeah. Okay. It's a high volume pulse. Okay. Fine. Somebody said it's a high volume pulse. Why high volume pulse? By the nature of the VSD, isn't it? By the nature of the VSD, you probably will have a good volume coming into the LV. And so it's one of the causes of a modified collapsing pulse. And so you would get probably a good volume pulse, correct? Okay, fine. What are the murmurs do you look for in this patient? What are the murmurs do you look for in a patient with a VSD? Yeah, pansystolic murmur you already have. You already have a pansystolic murmur. What else do you look for is what I'm asking you. What other murmurs are possible? Okay, you're looking for somebody is saying you're looking for an ESM at the pulmonary area. Correct, isn't it? Because of increased flow, you're looking at an ESM in the pulmonary area. Some amount of pulmonary artery hypertension will start developing over a period of time. And then somebody else says MDM at the apex, which is also correct. That is because of the increased flow through the LA to the LV. So you're getting an MDM at the apex. Correct. What else did you say? Crescendo, decrescendo murmur. Where? Where is that murmur going to be? Any other murmur you're looking for in this patient? In a VSD, correct. You're looking for a pansystolic murmur in the parasternal region. You're looking for a pulmonary artery hypertension features, which is the ESM. And then you're looking for the MDM on the other side. Okay, you can also get an AR, isn't it? When can you get an AR? When can you get an AR in a VSD? Okay, somebody is calling it a supracrystal VSD. Okay, a prolapse of the aortic cusp into the VSD, correct? Then you can get you can get an AR. So look for that also. Okay. So these are the murmurs that you technically look for whenever you see a patient with a VSD, apart from your pansystolic murmur. Auscultate the pulmonary area, auscultate the mitral area, auscultate the aortic area, and look for whatever. Okay. And VSD can come with various combinations, isn't it? You can get VSD with PS, which is called an acyanotic fallow, and you can get it in a tetralogy of fallow. Of course, this is not a tetralogy at all. But anyway, okay. Remember, VSD is a condition which can come. Okay. Various types of VSD are known. In a supracrystal VSD, you are actually expecting the murmur to be higher. You won't expect it in the lower left parasternal region. You will probably be looking at the second space or closer to that for a supracrystal VSD, though that thought is right. Okay. Predict his heart sounds. What do you think will be his heart sounds? S1, S2, 3, 4. What do you think are his heart sounds? Yeah. S1 will be muffled. Why? Why should it be muffled now? S1. Mitral valve, tricuspid valve. Probably nothing much. Okay. Somebody saying a wide split. Okay, possible. Yeah, correct. Maybe. Yeah. Then what else? What else? You may get an S3 on the other side because of volume. Correct. Otherwise, nothing much is going to be there. Okay. Fine. So you're looking for an S3. Okay, this is going to be a, a modified collapsing pulse, a hyperdynamic apex, a biventricular hypertrophy, and then you're going to get all the murmurs that you're talking about, and then maybe an S3, and maybe a wide splitting of the second sound. That's what you're looking at. Okay, now go on to this. What's the severity of his lesion? Do you think it's a very severe VSD or a mild VSD? What do you think he has? How are you going to judge the severity of his lesion? From that murmur, is it severe, not severe? What is it? Okay, a thrill. If there's a thrill present, it's a severe VSD or a small VSD or what is it? Small VSD, isn't it? Small VSD. Okay, if you got a very loud murmur, okay, Melody Roger, that kind of thing, then your the murmur is so loud that you can hear it. The larger the VST, then the murmur will actually come down because it behaves like a single ventricle, and then you don't have a flow gradient across the LV to the RV. So that's why the murmur will actually come down. So remember that you can get a very big murmur in a patient with a small VSD. A 3/6 would be somewhere in the middle, okay? But if you've got no murmur and you find a VSD, then probably you're looking at something like a very large VSD, okay? And of course, what else will help you? Will the pulmonary artery hypertension help you in any way to judge the severity of the VSD? Will it help you in any way? Yeah? Yes, one can be. Eisenmenger, somebody is saying. Okay. Eisenmenger is when you go to the extreme of pulmonary artery hypertension and you develop a cyanosis and a reversal. But any amount of pulmonary artery hypertension, the more the pulmonary artery hypertension, the more severe the VSD. That part is correct. What about the MDM at the apex? The MDM at the apex. What do you think will happen to the MDM at the apex once the patient has more pulmonary artery hypertension? Decreases, correct? It will decrease, isn't it? Because the flow decreases, the pulmonary artery hypertension increases. So somewhere in the middle, when the VST is moderate, you're going to have this pulmonary artery hypertension features with the MDM. As the pulmonary artery hypertension increases, the MDM will disappear and more pulmonary artery hypertension features will set in. Then he will go for a bidirectional shunt. Then he will go for a cyanosis and clubbing. And then he will go into Eisenmenger. So remember, in the beginning and the end, it may look almost the same. Okay. The presence of an MDM tells you it's a good flow VSD. It's a good flow VSD. So it can be beginning, okay, or it can be somewhere in the middle. But if you have no MDM, it can be either less severe, very small VSD, or it can be a very severe VSD. So the MDM comes somewhere in the middle, showing you that there is enough flow. Okay, so judging the severity will come from the murmur, the presence of the biventricular hypertrophy, the presence of pulmonary artery hypertension, which is main, and then the MDM, which is a sign of good flow or not. Okay, good flow or not can be a small VSD, no good flow, or it can be a very bad VSD with a severe pulmonary artery hypertension. MDM has disappeared. Was there, has disappeared. Okay, so remember, it can come in both the ends. Okay, right. Okay, how will his findings change if he develops Eisenmengers? What will happen to your VSD murmur? What will happen to the VSD murmur when you get Eisenmengers? Okay, yeah. What will happen to it? It will almost disappear, isn't it? Because there's no more this thing, isn't it? Cyanosis will come in, more pulmonary artery hypertension will come in, okay? The sound will become single, the second sound will become single, and then the MDM will disappear, and all you see is one pulmonary artery hypertension sitting there, okay? That's how it changes, okay? So remember that as the pressure equalizes, always blood flow is based on difference in chamber pressures, okay? Wherever they are. So in a VSD also, as you increase the right heart pressure, then the murmur will disappear, become smaller, and then it will disappear. And then you start getting only the features of pulmonary artery hypertension. Okay, fine. So let's go on. Okay. Do you think this man will be cyanosed? This boy, do you think he's cyanosed? Will he be cyanosed, this boy? Look at that problem and tell me, do you think he'll be cyanosed? No, because it's just, correct, correct. No, because he's got a good murmur there, isn't it? As long as you have a good murmur, that means he's not going to Eisenmenger's, right? So remember that. I'm just applying what I told you on the same problem and asking you a question. Okay, fine. Okay, let's go on. Right. Okay, what are the DDs of a pansystolic murmur in the parasternal region? DDs of a pansystolic murmur in the left parasternal region are, go on please. Okay, TR, okay, TR, TR, VSD, 2 are over, then rest. The next. Anything else? Two more. Two more, please. Oh, come. One more. One more. MR radiation. Okay, right, fine. Okay, accepted. Anything else? One. Infundibular PS, isn't it? You have to think of an infundibular PS. Okay. So those are the things. I have not written the MR radiation here. Okay. But remember that VSD, TR, infundibular PS, HOCM are the four things that can come in the lower left parasternal region. Somewhere around 3 to 4, 2, 3, 4, that area. These are the four murmurs that can come in. Okay. So how do you differentiate this? How do you differentiate these four things? It's easy, isn't it? Two are left, two are right. Okay, two are left side, two are right side. So your basic principle of a left heart murmur increasing on expiration, right heart murmur increasing on inspiration, those things, that you know already. Okay, fine. Plus you have the other findings, isn't it? You have the VST findings like what we said. Then we said TR, you'll do a inspiration, and then the infundibular PS with the normal P2, you've got a long systolic murmur in the lower left sternal border, that's an infundibular PS. And then your HOCM with all its findings. Okay, so I'm not really going into these, but remember, these are the ways, these are the things that you would look for. So basically look for LV or RV, and then look for inspiration or expiration, and then look for A2 and P2. I am just assuming that most of you are in the final year and will probably go on with all these. So I'm really not giving you the details of this, but remember, these are your differentials when you see a patient like that. Okay, right. Let's go on to the next problem. Okay, right. So a 30-year-old lady is brought with syncope, tiredness and walking. On examination, she has a low volume pulse with a BP of 90/60. JVP is raised with a prominent A wave. Okay, grade 3 parasternal heave is present. Apex is in the normal place. Fifth intercostal space, lateral to the midclavicular line. Ejection systolic murmur in the pulmonary area with a loud P2 and a narrow split S2. Okay, what's the diagnosis? Okay, somebody is calling it pulmonary artery hypertension. Okay, somebody is calling it PS with pulmonary artery hypertension. Somebody is calling it only pulmonary artery hypertension. Pulmonary artery hypertension due to what? What is this pulmonary artery hypertension due to? I agree there's pulmonary artery hypertension. There is a prominent A wave here. Okay, there's a grade 3 parasternal heave. You got an ESM in the pulmonary area. There's a loud P2 and there's a narrow split. All of them suggest pulmonary artery hypertension. What's the etiology? Somebody is saying rheumatic fever. Rheumatic fever, is that what you're saying? Yeah. And why are you asking for a PS with PH? No, that will never happen, isn't it? One excludes the other. So that's not what I'm looking at. Okay, right heart failure. Oh, you want to say right heart failure. Okay. Why are you calling it right heart failure now? Okay, somebody is calling it primary pulmonary hypertension. Okay, possible. Primary pulmonary hypertension is possible. There's a 30-year-old lady, and then she has got, oh, sorry, I did something. Okay, and then she has got all the features of pulmonary artery hypertension. There's no other murmur there. Okay, right. So you're basically staring at a pulmonary artery hypertension. Okay, fine. Let's be clear about that. All the features of a pulmonary artery hypertension. So basically you have to look at which of the 5 classes of pulmonary artery hypertension is it? Is it, PPH? Is it secondary to your, left heart disease? Is it COPD? Like that, the 5 classes of pulmonary artery hypertension that we normally think about, we have to think. And remember that once you label somebody as a PPH or a primary pulmonary hypertension, you're not looking at, any treatable cause. Okay, most of your causes are completely out of the world, and or it's idiopathic and nothing much you can do. So there are some rules when you diagnose a primary pulmonary hypertension that you should look for some things, correct? Okay, fine. So let's look at what are the murmurs you look for in this patient. If somebody said, why low volume pulse? Definitely, severe PPH will cause a low volume pulse, correct? It will cause, no flow, right? What are the murmurs you look for? Yes, ESM is already there. So what do you look for? No MDM, please. Oh, MDM to rule out something else. That I agree. In a PPH, what are you looking for? In a PPH, what murmurs? Let's get that straight first. You're looking for a ejection systolic murmur over. Then TR, correct. You're looking for a TR and also a pulmonary diastolic murmur, isn't it? You look for a pulmonary, this thing, incompetence, right? In ETM you look for. Okay, your Graham-Stills is what you're looking for. So PR and TR is what you'll always look for. Okay, the other murmurs you're looking for to rule out other causes. That I fully agree with you. I fully agree with you. Like I said, you can't really call somebody as a PPH unless you've ruled out the other causes, because you're not really doing much. Okay, what are the other cause of low volume pulse? Somebody was saying low volume pulse. So yes, it can happen in a severe PH. What else can cause a low volume pulse? Okay, any stenotic lesion. Let's be clear about it. Any stenotic lesion, right? AS, MS, PS, PPH, all these things where there's no flow, right? Every one of them is a low volume pulse. Okay, so that's what you're looking at, the other causes. And of course, any cardiac failure, all of them can cause a low volume pulse, a shock, those things. What investigation would you do in this patient? What investigation you want to do in this patient? Before you label her as a, you need to do an echo. For what? For what are you doing an echo? To confirm, rule out left side, correct. Left side, you want to rule out not only, an MS or, any valvular heart disease, and you also want to rule out, something like a congenital heart disease. Okay, like I told you, in a VSD, in the end point of a VSD, nothing much you will get. You'll only get a pulmonary artery hypertension. Your VSD murmur will disappear. Everything will look to you as if it is, PPH. Okay, remember that the second sound can become even single, narrow split. All those things can happen, right? So that's why an echo is very important to rule out a left-sided heart disease that can be, somewhat, some treatable cause can be there. So that should be always this thing. And then after that, okay, you can do your pulmonary artery, catheterization, things like that. But of course, you should talk about your ECG showing, suprasystemic pulmonary pressures with a tall R in V1, right axis deviation, S persisting in V6, all those things you can say P pulmonary, finish off all those things, then talk about an X-ray, which is again showing a, pulmonary oligemia. And of course, the pruning that you can get in any pulmonary artery hypertension, those things must be said. But of course, the echo is one crucial thing, because you do not want this thing. Okay, how to differentiate from PH? PH is the sound, isn't it? Sound will be loud in a PPH. It will be, soft in a PH. Okay, once you ruled out all that, and you called it a primary pulmonary hypertension, your options for treatment, you must, why the patient present with syncope? Yes, exertion syncope is a feature of severe PPH also, like your AS. Low flow to the carotids. Okay, fine. So you're basically looking at, the management would consist of what all? Okay, endothelial antibodies, go on. Then, okay, tadalafil, sildenafil, then, okay, vasodilators testing can be done, correct? CCBs can be given, correct? Okay, then anything else you can give? Prostaglandins, okay, all these things are possible, right? Nowadays, at least we have something, this thing. And when you label somebody as primary pulmonary hypertension, there are a few causes that you rule out. What are those causes? What are those things which are associated with the PPH? Which diseases are associated with the PPH? Okay, systemic sclerosis, sarcoidosis, HIV, correct, autoimmune diseases, all of them you should rule out, isn't it? All of them have some treatment somewhere or the other. Okay, not all of them will work very well, but these are the things that you should rule out before sickle cell disease, correct? hematological, this thing, it comes as 5, isn't it, in your primary pulmonary, your pulmonary hypertension classification. In the 5 part, you'll get the hematological causes. So you should think of all these causes, and they will have other ramifications. So you definitely have to rule them out. Now, like I said, what's the differential diagnosis is what this is very important. Okay. Now, before you dump somebody as a PPH, always rule out a silent MS, isn't it? A silent MS. Because once your MS becomes very severe, then you will not have much of a murmur there, because the flow through the mitral valve will be a trickle, and then the RV will rotate like that, and then your murmur is going behind, and so your MS will look exactly like a severe pulmonary artery hypertension query cause, right? But that MS has got a completely different trajectory and the management. You could still operate, things like that. So remember that you must rule out an MS before you label somebody as a primary pulmonary hypertension. Look for the diastolic murmur with all your sincerity. And like we said, an Eisenmenger's, especially a VSD, will look exactly like a PPH, and nothing much will be there, okay, except it will show you that there's a left ventricle which would have shunted earlier. So the presence of an LV on your examination tells you that there was a left ventricle which was hypertrophied before all this happened to him. So the left side ruling out is very important. The associated diseases are very important. After that only you go and call somebody as PPH. But remember, PPH can come in younger people, and it can present like what we said, a low volume pulse, a syncope, a tiredness, a dyspnea, and then they will never have a PND because you're not going to flood the lungs. Okay, remember all these things can be there. Okay, fine. Okay. And I'm not talking about sinus venosus ASD. Please leave it. Okay, let's go on to the next problem. Looking at how much time I have. Okay, fine. I think I will manage. Okay, 60-year-old man is referred to you for a health checkup. Okay, referred to you for a health checkup. That means he's fine, right? All you find is an ESM in the pulmonary area. Okay, there's a pulmonary area ESM. Okay, what are your possibilities? What findings would help you to make a diagnosis? What maneuvers are important? It's a pulmonary area, doctor. It's not a sclerotic aortic valve. Okay, correct. I agree with all of you that anemia is the first thing that you should rule out, isn't it? A hemic murmur is the first thing that you'll rule out. Anything else you'll think of apart from a hemic murmur? What are your causes of a just innocent ESM in the pulmonary area? Okay, any cause of, I agree with you, any cause of high flow, okay, like a thyrotoxicosis, pregnancy, exercise, whatever you want, all the high flow states. Then, beyond that is what I'm asking. Okay, somebody said that. Okay, it could be an ASD, isn't it? It could be, nobody has, the fellows walk through life. Your ASDs are not going to present very early. They're going to present late, even if they present. And so an ASD can just walk through life with nothing much happening to him, right? So you must look for that split, correct? So that's possible. That is referred to you for a health checkup. Okay, then what else? Somebody said TR. Why TR? I can't understand that. How come not exactly pulmonary area? Yeah, I think things that you all missed, I'll just put it up. Okay. One is the idiopathic dilatation of the pulmonary artery. Okay. Many people have idiopathic dilatation of the pulmonary artery, which is there, which will cause an ESM like that. And a straight back is something that you should always think of. Okay. Especially, I'm not asking about a 60-year-old man, but in a younger person, many times they walk around with a straight back syndrome, which will have murmurs, which will look like pulmonary murmur, mitral stenotic murmur, all kinds of murmurs can be there. And all you need to do is a lateral X-ray and then prove that he doesn't have a thoracic kyphosis, and that can compress the heart and give rise to murmurs. An ASD, like what we said, and a PS, isn't it? A PS, which is not really very severe, a mild PS can only present with, this thing, and nobody's really auscultating for the pulmonary heart sound. If you get it in a PS, then the pulmonary heart sound will be, what kind of heart sound do you get in a PS? What is the P2 in a PS? What is the P2? Soft? Loud? No. Soft, isn't it? It's a PS. So the valve is closing from up below, right? You don't have pressure in the pulmonary artery, so you can't really produce a loud sound, but it's a soft sound, right? And you're not having much of a flow, right? And your valve is not very mobile. Okay, fine. It's also late, isn't it? It's a soft, late sound. Okay, that's what you get. Okay, which can be confused even with an ASD for a, by splitting, things like that. Okay, right, fine. Okay, there can be an ejection click. That's what I'm saying. But remember that when you're referred for a patient who has got nothing much, remember that the hemic, like what you all said, that's common sense in place. Always look for a hemic murmur and then think of an idiopathic dilatation of the pulmonary artery. Think of a straight back, an ASD or a PS, which has gone through life without much thing. What maneuvers? What's the first thing that you would like to do when you see a person like that? Some things can be ruled out by a very simple thing. What do you ask the patient to do? Inspiration. Okay, that's for the diagnosis of PS and other things. Okay, ASD and all. Okay, looking for a fixed split and all that. Ask the patient to stand, right? When you ask the patient to stand, immediately you're reducing the right ventricular volume. Okay, when you do that, then you immediately, the half the murmurs which are, looking very loud or lying down will actually disappear when the patient stands up. So the simplest way of, giving a disadvantage to a pulmonary murmur is to make the patient stand up. Okay. So all murmurs, before you think, oh, something greatly wrong with this man, ask the patient to stand up and auscultate. Then you get the correct severity of that pulmonary murmur, and then you can assess further. But remember, this is a common problem in your OPD, and so you must do these things when a patient comes to you. Okay, so let's move on. Okay, now I'm just going to put a little short things for you. Okay, so you get an ejection systolic murmur in the pulmonary area with a normal P2. What are your possibilities? Normal P2. ESM with a normal P2. Anybody? Okay, flow murmur, correct? Okay. Okay, hemic. The causes that we told now, isn't it? Your idiopathic dilatation of pulmonary artery, all these things, they can present with a normal P2, correct? Okay. Even a mild PS can be a normal P2. Okay. Soft or absent P2? Soft or absent P2? ESM with a soft or absent P2? Anybody? Okay. Somebody saying PS. Correct. Whenever you're getting a soft or an absent P2, then your diagnosis is a P2, PS, which is a late soft sound. Okay. Right. Fine. Then you go to the next one. Loud P2. ESM with a loud P2. Yeah. Okay, that's, simple for you. That is your pulmonary artery hypertension. Any cause of pulmonary artery hypertension is what we are thinking of. Okay, right. Wide split. ESM with a wide split. ESM with a wide split. I'm not saying just wide split. ESM with a wide split. Yeah. Okay, somebody is saying ASD. Okay, everybody is saying ASD. ASD is a wide fixed split, isn't it? Okay, right. Okay, we'll come to that. Okay, we'll come to that. But generally what you said is right. Fixed split is always an ASD. Okay, and a narrow split is ESM with a narrow split. Pulmonary artery hypertension. Okay, so we got this right. Correct. Now, what I want you to understand from all this is whenever you hear an ESM in the pulmonary area, your next question is what is the P2? Okay, your P2 gives your diagnosis. Correct. When you see an ESM in the pulmonary area, is it a normal P2? Is probably something innocent. Okay. This is a soft or absent P2. You're looking at a PS. So loud P2, you're staring down a pulmonary artery hypertension. So fixity and width of the split, then you're looking at probably an ASD, something like that. Okay. And a narrow split, you're looking for a primary pulmonary artery hypertension of whatever cause, whatever may be the cause can be there. Okay. So now you all know the explanation for a fixed split. Why is there a fixed split in an ASD? That I think you all will be asked in your exam. Why is there a fixed split in an ASD? Equal flow across both. Flow equals across both. No. Flow doesn't equal, isn't it? What flow equals? There's an ASD. So you're getting a flow from the LA to the RA and then to this thing. Across pulmonary artery and aorta. No. We're not talking of aorta at all. Okay, inspiration reduces shunt fraction. You're talking only of the RV volume. Don't go to the left side, doctor. You're talking only of the RV volume, isn't it? The RV volume is the same. Okay. Normally, the reason for the physiological splitting is the increase in the RV volume during inspiration. Correct. During inspiration, you're drawing a lot of blood into the RV, so your P2 is closing later, and it's a low resistance circuit, etc., etc. But here in an ASD, whatever you get during inspiration and the shunt volume from the LA to the RA, they equalize. Okay. So during inspiration, more blood from the veins. During expiration, more blood from the shunt. So ultimately, whatever the RV receives is the same during inspiration and expiration. That's why there is no, doctor, don't go near pressure equalization diode, atria. That's not right. So the volume in the RV, both during inspiration and expiration, is the same. That's why you get the fixed splitting. Okay, please get this correct because it's an often asked question. Okay, right. So let's go. Okay, I missed out on that. ESM in the pulmonary area with a single S2 is what? Single S2. Single S2. Large VST. Fallow, isn't it? Most probably you're thinking of a fallow, right? And this may not be the P2 at all. This may be the A2. That's how you have to think. Okay, fine. Right. Okay, fine. Eisenmegerization is also correct. Okay. For you to remember the causes of a wide split S2, okay? One is the AST, one is the PS. Remember that sound is soft and late. Okay. The RBBB, anything that delays the ventricular, emptying is going to delay your P2. So RBBB, RV failure, RV infarction, LV ectopic pacing, and your VSD and MR, which are actually that side. Okay, fine. Right. Now let's look at this side. Some more things are there in this slide. Okay. There's one more question here on reverse splitting, and these are your causes of reverse splitting. Now, please remember, these are sometimes asked in your exam, and you can get because of AS and PDA and an LBBB, all of them will cause a reverse splitting by delaying the aortic second sound. Okay. So what I want you to learn is when you get a pulmonary systolic murmur, all you're looking for is the P2. The P2 gives you a lot of information. So look at your PT and then look at your splitting, and that's when you take it from there. Okay, so let's go to the next one. Okay. Sorry, did I miss a slide? Yeah, I missed the slide. Okay, so a 15-year-old boy comes with fever and, fever and pain in the right knee of a week's duration. 2 weeks ago, he had pain in the left wrist and right ankle, which disappeared with painkillers. Examination reveals a pansystolic murmur at the apex. Very simple one. Very simple one. What is this? Okay, this is a rheumatic MR, migratory arthritis. Okay, this is an acute rheumatic fever, isn't it? It's an acute rheumatic fever with a carditis. That's how you should tell. It's not rheumatic heart disease. It's an acute rheumatic fever with a carditis. Okay, so you're getting, what other murmurs can you get in a carditis? Yeah, what other murmurs can you get in a carditis? Okay, you can get an AR, you can get a Carey-Coombs murmur. All these things can be there. Correct. Fair enough. Okay. So the diagnosis is probably because of the age and the migratory arthritis and the presence of this thing. And rheumatic arthritis, you remember it's a pancarditis. You can auscultate for a pericardial rub here. Okay. And then there is an endocarditis, and this patient can go into failure, which tells you that there's a myocarditis. So all three can be there. And your prognosis in this patient. Now the mother wants to know, now he has got one murmur there. What's going to happen to him? What will you say? What will you say? This murmur will be there. What will happen to him? What are you going to say? Will this translate into one mitral regurgitation in the future? What are you going to say? What are we going to say? What will happen to this person with an acute rheumatic fever in future? It will improve, need prophylaxis. Okay. No. How do you treat this patient? This patient you have to treat, right? These are carditis. So what did you do? What will you do? Yeah, you have to give the steroid, isn't it? It's a pancarditis. You have to give the steroid. In addition to aspirin, you may have to give a steroid because there's a carditis, and to some extent, it prevents the progression of the lesion to this thing. Okay, but remember, because it's a mitral regurgitation, the chances of going into a valvular heart disease very early on is less. If it's a Carey-Coombs murmur and you're thinking of mitral stenosis, then the progression sometimes can be fast because you can get a juvenile MS. But here, probably it's going to give a long time for you, but you can't really predict what will happen to him. Treatment will, whether the steroid will prevent this person from going into a rheumatic heart disease is not really clear. Okay, it will definitely save life now. Okay, he won't go into failure. He'll be all right. No, he's going to survive this episode of rheumatic heart disease. That is correct. Okay, but how much it prevents the progression to the valvular heart disease is not very clear and not very sure. So prognosis is guarded. We'll have to tell the patient to come for follow-ups and then assess the this thing of the MR. And given the timelines of a rheumatic fever and the development of rheumatic heart disease, remember the MS comes first, the MR and the AR will come later after the valve is affected, and the AS will come somewhere in the middle. So depending on all this, remember that the MR will probably give him time. So he's not going to be sick or tired by the time he's 20. He may be, manifesting that MR much later. Okay. So remember that. Okay. No, for carditis, it's always a steroid that is given in addition. Okay, right, fine. So let's go on to the next one. Okay. Yeah. So this is where I asked about the causes of MR, and then I wrote for you the big four causes of an MR. Okay. The big four causes of an MR, this in this order should be there: rheumatic heart disease, your MI, papillary muscle dysfunction, cardiac rupture of an ischemic, event, and then an MVP and infected endocarditis. These are the big four. What are your other causes of an MR? If somebody asks you, what would you say? The other cause of an MR is, what would you say? Okay, DCM, functional MR, go on. AV canal defects, some more. Okay. Okay, trauma. Okay, trauma is probably the last thing that you should ever mention, right? Okay. Mitral annular calcification is something that you should always consider in the elderly. Okay, you take an X-ray, you say, nice calcified mitral valve will be there. So mitral annular calcification is something that you should think. Acute rheumatic fever, we already say. LV dilatation because of CCF. HOCM, you should think of, isn't it? HOCM can be associated with the MR that you should think of. A left atrial myxoma can present with an MR systolic murmur. Then congenital, valve defects, those things can be there. I'm sorry. Okay. So these are the things that you should think of in addition to the causes that we talked about under MRTR. These are the causes that you should think of, okay, when somebody is asking you. But if you think in real life, what are your best four possibilities for an MR? The big four will always be the big four. So rheumatic heart disease and your ischemic heart disease with MI, PMD, and an MVP and an infected endocarditis. These are the big four. After that, you should think of many other causes. Some more can be written here. I'm not really written here. Okay, fine. So that's about that case. Now we go to the next one. A 55-year-old man with probable cirrhosis is treated with diuretics. He has ascites and pedal edema. The splenomegaly of 3 centimeters. The endoscopy reveals no varices. On questioning, he complains of fatigue and breathlessness in addition, but no PND. He has no cardiomegaly, normal heart sounds, no murmurs. What diagnosis could have been missed? And what physical signs will reveal it? Anybody? He's diagnosed to have cirrhosis. And then he says there's no varices. There's a splenomegaly, but there's no varices. So the gastroenterologist is looking at you and saying, okay, somebody said that. It's a constrictive pericarditis that you would think of, isn't it? Ascites precox. So whenever you look, when you see a patient who looks like cirrhosis in every form, but you have something missing, something odd in him, because you are normally looking for a cardiomegaly, which is not there. Your heart sounds are reasonably all right. You may get a pericardial knock, but you have to concentrate and auscultate for that. There's no impressive murmurs sitting around the place. So then your diagnosis of constrictive pericarditis comes from very simple things. What makes you diagnose a constrictive pericarditis clinically? Okay, Kussmaul sign, white descent, then go on. What else? What else? What else will be there? Yeah? Sorry, I missed that. Yeah. Pulsus paradoxus, isn't it? Looking for a pulsus paradoxus and then looking for a JVP is what you should think of, isn't it? So remember that the diagnosis of constrictive pericarditis comes from the vital signs. So many times patients with cirrhosis, the JVP is missed. But remember, you have to look at the other side also. Anybody with a very tense ascites will have a JVP, which will look as if there is a JVP, there's a heart disease, but nothing. It's just a compression. It's like your, reflex that you're calling, because of compression of the liver, and that's why you're getting a JVP. That can happen. So the person with a very tense ascites, just because he's got little JVP, don't call him cardiac, don't call him constrictive pericarditis. But otherwise, if you don't have a very big ascites, okay, you don't have a hepatojugular reflux kind of situation there, then you must look for a JVP in people like that who are presenting with something which is odd. There's no varices. You got a splenomegaly. Generally, we're expecting portal hypertension to be there. You're not having it. Then you look at the JVP. And look at the JVP and look at it for your, prominent inspiratory increase, and then your prominent Y descent. Look for all that and look for a pulsus paradoxus. Okay. So pulsus paradoxus, yes, you can, you have to document it not with the pulse, but with the BP, right? How do you measure for a pulsus paradoxus? How do you measure the BP for a pulsus paradoxus? Looking for what? Okay, more than 10 millimeters. Initially, yeah, but only during inspiration, then expiration. So you have to push that BP apparatus, put the thing up and then come down like that. Okay, and then only you will hear both during inspiration and expiration. That's how you document. And that difference must be more than 10 millimeters. Only then you think of a pulsus paradoxus. Otherwise, you're holding the hand and seeing a pulsus paradoxus is correct. I'm not saying no, but the way to document it is with the dip in the BP that you get, and that should be more than 10 millimeters. And for that, you raise the BP here during expiration, come down here during inspiration and expiration. That's how you monitor. No, you increase the BP, okay? When you're hearing sounds only during expiration, then you come down when you're hearing sounds during inspiration and expiration, then that difference in the blood pressure should be more than 10 millimeters. That is when you call it as pulsus paradoxus, and that's how we document a BP. So this constrictive pericarditis is one condition where your diagnosis mostly rests on your vital signs. The heart is very unimpressive, isn't it? Heart is very it's a small heart, it's a quiet heart. Nothing majorly is going wrong there, except for the pericardial knock, which you to be, careful enough to auscultate. You're not going to get much. You're going to make your diagnosis based on the JVP and your Kussmaul's and your Friedrichs, and then you're going to look at the pulsus paradoxus. That's how. So remember that somebody who looks like cirrhosis but is not exactly cirrhosis, the differential diagnosis always ascites precox of a constrictive pericarditis, and the whole diagnosis comes from the vital signs. Okay, fine. Now I'm just going through a few quick things. What are the conditions in cardiology where you take a deep breath and make a diagnosis? Take a deep breath and make a diagnosis. Which conditions? Okay. Take a deep breath and make a diagnosis is not, you're inspiring, right? Okay, somebody saying, "Ho come MVP." Differentiating right and left murmurs. Okay. Basically, you're looking for the right murmurs, isn't it? Take a deep breath and make a diagnosis. Is for a Carvalho's sign of a TR, and then you're looking for a PS. And the PS, the sound will come, the click will come during expiration. Remember that. And the CCP, where you're getting an inspiratory rise in the JVP rather than a fall. And then you're looking for the splitting of the sound, okay, during inspiration and expiration. That's what you're looking at. Okay, fine. So taking a deep breath and making a diagnosis more for a right heart, but also can be looked at for an inspiratory increase in the JVP like in CCP, and you're looking for this. Okay, now let's look at one more thing. Breathe out and make a diagnosis, which is what some of you were trying to tell me. So looking for something in expiration. Okay, so if you look at those causes, there you will get your HOCM, MVP, wherever the ventricular volume is decreased, these murmurs will increase. So that's why your expiration, and so you're not getting much blood there. So then again, left heart murmurs will all increase during expiration, and the PS ejection click will come, and the ASD. Now, why I'm saying the ASD is because if you expire and still your split is wide, then it is wide. Okay, remember that. If you're getting a wide split in the OPD and you're thinking, oh, what is this? Maybe he has an ASD. All you have to do is to make the patient stand up, okay, and then expire, which is the maximum disadvantage for the ASD. Correct. All you're doing is you're completely knocking out the right heart. So then if he's still wide, then he's wide. That split is wide. You understand that? So that's why I said breathe out and make a diagnosis. Split still heard during expiration is an ASD. Okay, most of your splits will disappear when you expire, but it's still hurt during expiration is an ASD. That's what we are talking about here. Okay. Okay, stand up and make a diagnosis. Just stand and make a diagnosis. Again, the same things, MBP, HOCM, and ASD to rule out. So in a crowded OPD, the simplest way of diagnosing an MBP or a HOCM is to ask the patient to stand. Okay, decrease your ventricular volume, the MBP is going to prolapse more, the HOCM is going to get more obstructed, and your ASD will still remain split. That's your ASD. Okay, so many times this was taught to me by cardiologist when I was an undergraduate, that he used to simply make the patient stand. Okay, you want to see an MVP, make the patient stand and auscultate, you will get it, he will tell. Okay, so these are some of the things that are small tricks that we use in, in a situation where you're not really looking for a murmur, but you're, surprised by a murmur. These are the small maneuvers that you can do. It's much tougher to do the leg raising and all that stuff, but these are more simpler. Okay, even the Valsalva is difficult to teach the patient. You do all kinds of, nonsense. So instead, these are simpler ways of making a diagnosis. Okay, right. Now, one more puzzle. Echo positive, no murmur. Echo is showing some disease, heart disease, but there are no murmurs. Tell me cardiac conditions where, okay, somebody said silent MS, go on. Then, go on. Only silent MS, anything else? Okay, large VSD, correct, doctor. Large VSD. Acute MR, correct. Acute MR. Then TR, okay, you can hear everything. Small VSD will be very loud, isn't it? A murmur will be very loud in a small VSD. Somebody is calling it infective endocarditis. Okay. Small ASD. Okay. We're going for all kinds of imaginations. Okay, right. Okay, I am putting up some problems and now you have to tell me, okay? 65-year-old diabetic with normal BP with pulmonary edema with no murmurs. What does he have? 65-year-old diabetic with normal BP coming with pulmonary edema, no murmurs. What does he have? What does he have? Probably an MI, correct? Isn't it? An MI, you could even echo showing you wall motion abnormalities. It can even show you some kind of papillary muscle dysfunction, isn't it? It's an acute MR. You will not get your murmur. Okay, that's what you have to remember. Okay, right. 20-year-old female with pulmonary edema, no murmurs. 20-year-old female with pulmonary edema, that's an MS, isn't it? Please remember, when you get a young person with the pulmonary edema, you're not looking at an ischemic heart disease, isn't it? You're looking for a silent MS. And remember, in that galata of pulmonary edema that happens with so many, everywhere, creps and bronchi, you're going to miss your MDM, which can be, this pulmonary edema is obviously a person who's got a good going MS. So sometimes you may miss it, or it could be a silent MS, and that's why you're not hearing the murmur there. So remember, 20-year-old lady with pulmonary edema, look for an MS. The echo is going to show you. The clinical examination may not pick up. Okay, right. 45-year-old with fever, weight loss, 2 months, and dyspnea. Echo showing you something, but the person doesn't have any murmur. 45-year-old fever, weight loss, 2 months, dyspnea. Echo is showing you something, but nothing much is there. So 2 months fever, weight loss is very simple, no doctor. What is it? Okay, somebody's calling myxoma, you'll get a murmur. Okay, you're thinking pericardial, isn't it? You're thinking pericardial. Remember, this is TB. You got a fever, weight loss, 2 months. In this country, what are you thinking of? You're thinking of a TB, isn't it? A cardiac TB is either a pericardial effusion or it is something like a, constitutive pericarditis can be possible, right? Okay, somebody said is in infective endocarditis. Fair enough. I agree with you, infective endocarditis, but infective endocarditis to not produce a murmur has to be acute, isn't it? To not produce a murmur has to be acute. A subacute infective endocarditis will usually have a murmur, isn't it? Okay, so that's the important thing that I want to tell you, that you can get, now let's look at this. So 50-year-old lady with acute onset dyspnea, raised JVP, no murmur. What is this? 50-year-old lady, acute onset, the PE, correct doctor, it's a PE. So remember, everything in cardiology is not a murmur, okay? Everything is cardiology is a setting. Okay, always, that's why we keep on insisting that please take your history, then go to examination, and then think. The most important component that is missing is the thinking part, isn't it? You have to put it together like a puzzle. If you don't, then you will simply go on doing investigations without any reason, okay? So it's good to make a clinical diagnosis. So all these conditions, especially when they're acute, do not have a murmur. That's very important to you, okay? So Let me see if I have. Yeah, that's it. So these are 4 conditions which I showed you where there is no murmur at all and the patient. And remember, in an acute MR or TR, you're not going to get a murmur, okay, because there's no pressure difference developed for you to get a murmur. And things like a PE, you're not going to get a murmur because there's nothing there to produce a murmur for you. Okay, but these are all very dangerous things where the heart looks normal because you're not getting a murmur there, and your sounds you have to auscultate carefully to make a diagnosis. Okay. 65-year-old man, okay, this is what? 65-year-old man with a septic arthritis was one of my patients. Septic arthritis with a short onset dyspnea. Septic arthritis with a short onset dyspnea. IE. Okay, right, fine. That's an IE, right? So this patient came to me. Remember, whenever you have a septic arthritis, you're looking for 2 organisms, Staphylococcus and an Enterococcus. Both can occur. Okay, when you're getting these things, staph, you always have to do an echo. 25% of staph infections can present with IE. So an echo is a must in all staph infections. And also in Enterococcus also you do an echo. So these are acute infective endocarditis need not present with a murmur. That's what you have to remember. So an acute MR, acute TR, and an infective endocarditis, which is acute, things like pulmonary embolism, like and a constrictive pericarditis or a pericardial effusion, these things do not have a murmur. Okay, so the absence of a murmur is not ruling out heart disease. That's what I wanted to show you with this slide. Okay, I think this is probably the last. Sanketa, I'm just exceeding by a few minutes, okay?
We are enjoying, ma'am. Perfectly fine.
Okay.
Yeah.
This is probably the last. 20-year-old student is brought with high-grade fever and fatigue. On examination, JVP is 8 centimeters, tender liver is palpable, auscultation reveals a grade 2 pansystolic murmur in the tricuspid area. TC is 20,000 and ESR is 120, okay? What history is important in this patient? Okay, IV drug abuse. Okay, that's very simple, isn't it? So you're looking at, again, you're looking at the context. Okay, the diagnosis of cardiology comes from the context. You're looking at a 20-year-old student, high-grade fever, fatigue, and he's got all signs of right heart problem. Okay, and there is a, probably something in the tricuspid area. It's only a grade 2. Remember, your murmur is not going to be impressive because it's an acute infective endocarditis. Okay, and your ESR and your count are showing you that it's an acute infection. And you, in this age group, you would probably think that there is a right heart problem and infected heart. So probably coming to the end, what are the causes of TR? Just list the cause of tricuspid regurgitation. Okay, correct. The first one is functional. I fully agree. Then go on. Go on, please. PH. Okay, that's fine. Bronchial carcinoid, MS, PH, RV infarction. Go on. Tricuspid valve prolapse, carcinoid. Go on. Okay, DCM is combination. Those are all combination, but anyway, right. Any more? Any more? Severe MS is functional, isn't it? So almost 90% of your TRs are functional. That's the first thing to remember. So whenever you get a TR, look for a pulmonary artery hypertension. Your student who had IV drug abuse did not have pulmonary artery hypertension, isn't it? So pulmonary artery hypertension is the first thing that you rule out whenever you see a TR. And these patients, we must rule that out, because then you go to the 5 class of pulmonary artery hypertension and find out which cause. COPD with pulmonary artery hypertension with TR, all those things are possible. Okay, that's first. But apart from that, there are causes of TR which you did not mention. I'm just putting it up for you. So this is correct. Then the organic TR is IV, rheumatic heart disease. Rheumatic heart disease in a small percentage, 5 to 10% of rheumatic heart disease can present with the tricuspid valve involvement, isn't it? Most of the time it's mitral, then aortic, then pulmonary and tricuspid, small amount. Tricuspid valve prolapse, she also said carcinoid. You didn't talk about Epstein's, isn't it? Epstein is a very important cause of a TR, atrialization of the ventricle, and then you got a TR, and then you got an LV apex, and then you got a cyanosis, multiple clicks. That's all Epstein's. Okay, please remember, Epstein's is an important cause of a TR. Endomyocardial fibrosis, like you said, your DCM you can get. RV failure and RV infarction are 2 causes of a TR that you can get. And cushion defects can occur. Okay, so these are the cause of TR. Sometimes it's asked in the exam, what are the cause of TR, and then we should not be looking at. Okay, so I'm just going to quickly revise, Sanket. Just going to run through all the slides once more so that it goes in nicely. Okay, and that's probably the end. Okay, 1 minute. Okay, So in the first case, we talked about, DCM, and we said there's no pulmonary artery hypertension. And then we discussed the mechanisms. And then we talked about MRTR combined, and we talked about the etiology of DCM, which you all now know. The second case, we talked about 10-year-old boy. We talked about a VSD presenting as a, infective endocarditis with this thing. And we talked about the various grades of VSD and how we recognize. And then we talked about the murmurs in the, parasternal region, and how do we differentiate. Then we talked about primary pulmonary hypertension and how important it is to look at the treatable causes of pulmonary artery hypertension before we dump them. And then we talked about how we manage a pulmonary artery hypertension. And the fourth case, we talked about a simple innocent pulmonary artery murmur coming into your EST, and how the second sound is what decides what is the cause of your pulmonary artery hypertension. Then we talked about the boy with with a rheumatic heart disease, rheumatic fever presenting there. Then we talked about the causes of MR. Then we talked about a constrictive pericarditis, which is an often misdiagnosis. And then we talked about the maneuvers, like taking a deep breath, breathing out, a standing up diagnosis, and conditions is present with no murmur at all. And then finally, we ended with the TR. I think that's it. And thank you.
Thank you, ma'am. It's amazing.
Thank you, Sanket. Somebody is asking, how do you differentiate? What is that MR and TR? Okay, MR and TR. Okay, MR increase on expiration, TR increase on inspiration. Apart from that, you inch from there. Put your step inch by inch from the MR to the TR area. And then you find a gap, and then another murmur coming in. Then probably you're thinking there is an additional TR there. Okay. Otherwise, it's with, context. Anybody else, anything you want? It's done?
Yes, ma'am.
Can you explain why no pulmonary artery hypertension? In what? In a DCM. Okay, there's no time. And before pulmonary artery hypertension develops, you already have a TR on the other side. So you don't need the pulmonary artery hypertension to get a TR. That's what I meant. But over a period of time, you can. Any left heart can cause a right heart pulmonary artery hypertension. But the point is that's going to take time. You can't do it in 1 month. It has to be done over years. That's it.
Yes, sir.
Okay. Thank you,
Thank you.
Sanket. Thank you. Thank you all.